Hello everyone, this is Katie Du Bois doing my case study on cystic fibrosis. This case study reviewed a white male infant who, after an unremarkable birth, demonstrated abdominal distension, bilious vomiting 24 hours after birth, and no bowel movement. An X-ray of the abdomen showed distended loops of bowel without air. The infant was taken into the operating room, and an exploratory laparotomy disclosed meconium ileus and atresia of the distal ileum. Small flecks of calcification were present on the peritoneal surface. The involved segment of the ileum was resected without complications. The patient in this case study presented with the following lab work. White blood cell count was 7,500, hemoglobin 8.5, platelets 631,000, prothrombin time 14.5 seconds, serum albumin 1.8, sweat chloride 110, and the stool smear was positive for fat. After the patient's surgery, a sweat chloride analysis was unsuccessful. The follow-up was not pursued. After 9 months, the infant presented with failure to thrive, poor weight gain, and edema. The infant had been having 4 to 8 bulky, foul-smelling bowel movements per day. The infant had experienced bronchitis in the past several months. The infant was pale, small, appeared malnourished, with pitting edema to the extremities, a protuberant abdomen. His liver was palpable at 4 centimeters below the right costal margin, and the infant had coarse rhonchi and scattered rales. The chest X-ray showed streaky markings on all the lung fields. The infant went into respiratory distress, was febrile, had increasing tachypnea, and had physical findings suggestive of worsening pneumonia. 1 day later, the patient had a white blood cell count of 24,000. His sputum culture grew Pseudomonas aeruginosa and Staphylococcus aureus. Unfortunately, the infant died 1 day after admission, despite antibiotics and intensive support because of respiratory distress. The research articles that I chose for this topic demonstrated the pathophysiology of cystic fibrosis, the genetic components of cystic fibrosis, and the etiology of the cystic fibrosis transmembrane conductase regulator gene and protein. I picked these articles because they had a good foundation for how cystic fibrosis is displayed, how it is inherited, and how common cystic fibrosis is as a recessive disease. The inheritance pattern of cystic fibrosis. Mutation of the CF gene causes absence or dysfunction of the CF transmembrane conductase regulator, or also known as CFTR protein, which works as a chloride canal in the apical membranes of epithelial cells. The CFTR gene affects the production of secretory granules, mucus, and intercellular response. According to Kumar, Abbas, and Astar, cystic fibrosis is an autosomal recessive disease, and affected individuals carry mutations on both alleles, so the affected person will receive one mutated gene from each parent. Frequency of genetic defect in CFTR protein function. Cystic fibrosis affects 70,000 people worldwide. Primarily, the people that are most likely to be affected are of European descent. A 3-nucleotide deletion causes a structural change in the CFTR mRNA, which causes a reduction in the translation process. The CFTR gene is located on human chromosome 7 and produces the CFTR protein, which is responsible for regulating the chloride ion content of epithelial cells that line the stomach, lungs, and nasal cavities. These cells normally secrete mucus and sweat. Individuals with CF lack this protein, and therefore cells produce sweat with a high salt content and thick mucus, which results in the positive sweat chloride test. The pathologic manifestations of cystic fibrosis include the following. The inability to regulate chloride results in electrolyte imbalances. Pancreatic exocrine function is destroyed because of blocked pancreatic enzyme movement through the digestive tract. This can also cause meconium ileus in neonates. Mucus plugs cause poor digestion of fats, proteins, and carbohydrates. Infection and inflammation of the lungs and sinuses and respiratory distress. Liver cirrhosis. Airway obstruction. Infection with Pseudomonas aeruginosa. And it can also cause male infertility and that's thought to be caused by congenital absence of the vas deferens. So how does this research relate to the cystic fibrosis case study? The infant displayed many clinical manifestations that I went over in the previous slide. When the infant was born, he had many gastrointestinal symptoms similar to cystic fibrosis, such as distended abdomen, meconium ileus, and atresia of the distal ileum. Unfortunately, they were unable to collect the sweat chloride tests, and they didn't acknowledge that his stool was positive for fat in the beginning, and the patient never followed up. When the patient was readmitted, the infant had failure to thrive and was producing several bulky, foul-smelling bowel movements with stools that floated. Not long after that, the patient was in respiratory distress and had scant subcutaneous fat as well as pitting edema and a chest x-ray that showed increasing pneumonia. He also had increased white blood cell count compared to his prior labs. So in his prior labs, the patient's lab showed positive fat in the stool smear, a prolonged prothrombin time, and a low serum albumin, which could indicate malnutrition, and increased sweat chloride on his sweat chloride test.